So thank you very much, everybody, for joining the next edition of Oncology Beyond the Obvious. As you know, this has become extremely popular and well-respected monthly webinar. And we have always tried to innovate to give you the best. So the new innovation is that we start each time with a recap of what happened the last time. So if you remember what we did the last time, it was the title of the publication was Single Route CNS Prophylaxis for Aggressive NHL, Real World Outcome from 21 Academic Institutions. And this was a change from our usual phase 3 randomized landmark publication, because we thought that this was an important question being answered. And we were not really sure whether the real world is really ready to change as what was mentioned as a single route CNS prophylaxis. Now, for a CNS prophylaxis in high-grade NHL, we have two options. Either we use high-dose methotrexate or we use intrathecal methotrexate. And before the last month's Oncology Beyond the Obvious, we actually did a survey. And the answers that we got were really divergent, representing what is happening in the real world. So not more than 50% opted for one of the options, one of the three options that we had given. So this divided opinion was also seen in the panel discussions about what is their day-to-day practice. And what was really important, which I'm sure the audience understood, was the high quality real world data collected by Dr. Veena Nair and collaborators of more than 5,000 non-Hodgkin lymphoma patients from India. And that real world data is exactly identical to the real world data in that publication from 21 academic institutions. So the final conclusion from that was that there is no evidence at present for using high dose methotrexate as CNS prophylaxis, as a sole route of CNS prophylaxis in high-grade NHL. So I'm sure that you all have understood that conclusion, and that video is available on YouTube channel. So if you have missed that, then you're most welcome to access it and look at it again at your convenience. Now I'll turn to the second part, and why is that Oncology Beyond the Obvious has become popular and respected. The first is that Dr. Amish Vora really spends a lot of time in selecting the right publication that is of current interest and relevance to the Indian context, as well as to the SAARC countries and other low and middle income countries. The second is that we have appropriate co-acquirers. We have an interview, we have a moderator, and then we have an expert conclusion. So these three are really people who have been selected because they are top of the class with their personal experience in this specific topic. There is several rounds of back and forth. In fact, we do a dress rehearsal, we do the recording ahead of time just to see how the question flow should be, what should be the answer, can we fit that in the time frame. And then when the actual session occurs, it is not a recorded version, it is the live version. So a lot of pains and a lot of work goes in the background to make this most appropriate and most practical for the real world action that you can take in your day-to-day practice. And this is the reason now we have participants and audience from more than 13 countries who are regularly logging in or viewing the Oncology Beyond the Obvious series. With these few words, we now move on to today's program. And you know that we have already announced not only today's program, but next month's Tuesday's program as well. So all of you can be really prepared for what you need to do. So the three stalwarts for today are Dr. Jaya Ghosh, who is the interviewee, Dr. Vineet Talwar, who is the moderator, and Dr. Kalaichelvi, who will be the expert conclusion. I now hand over to Dr. Amish Vora to take care of the further proceedings. Over to you, sir.
Thank you so much, sir, for such a wonderful introduction, and recapping the previous OBTO, and Dr. Parikh sir and I have decided that we'll continue doing the recapping of the previous OBTO in each of the episodes. With that, let's move on to today's topic. And today's topic, as you all know, is Pembrolizumab in first line recurrent or metastatic CAC. So I will, as always we do, I will first present the snapshot of the paper, what we are going to discuss for next 1.5 hours. Can I have my first slide, please? Okay. Can we make the full screen? Can we make this into, yes, okay. So next slide, please. So this is an NEJM article in late 2021, following which FDA approved this particular regimen in the treatment of CA cervix. The title is persistent Pembrolizumab for persistent, recurrent, or metastatic cervical cancer. And the trial is called as Keynote 826. Next slide, please. Okay. So inclusion criteria, normally we select a slide where there are not all the inclusion criteria. So today I decided not to deviate from NEJM article. And eligible patients were 18 years and above who had persistent or recurrent or metastatic adenocarcinoma, adenosquamous carcinoma, or squamous carcinoma of the cervix that had not been treated with prior systemic chemotherapy alone. That is the first line in the metastatic setting. Prior radiotherapy, including chemoradiotherapy, was permitted if it has happened 2 weeks later or 2 weeks earlier. Performance status of 0 to 1, as it always happens everywhere, had a measurable disease based on RECIST criteria, and a newly obtained biopsy or the previous biopsy, which was taken from non-irradiated site, if they were available, were collected for PD-L1 status determination. Next slide, please. The trial design was, it is a double-blind trial conducted at 151 sites in 19 countries. 1-to-1 randomization between pembrolizumab and placebo. But all the patients in the trial, they all received paclitaxel 175 milligram per meter square, plus either cisplatin 50 per meter square. I understand the dose is slightly on the lower side, or carboplatin AUC 5 every 3 weeks. Pembrolizumab was given for 35 cycles, that includes 2 years of the treatment. Minimum of 6 chemotherapy cycles were given. If the investigator felt that there is a very good response and they want to continue beyond 6 cycles depending on tolerability, they were allowed for that. Now, there was one more addition in this trial, that apart from pembrolizumab stroke placebo plus paclitaxel plus platinum, patients were allowed to be given bevacizumab 15 milligram per kilogram of the body weight every 3 weeks, depending on the local investigator's discretion. Next slide, please. So this was the demographic and disease characteristics. There is nothing much here to discuss in the top lines, but if you see de novo metastatic, that is the disease status at trial entry, de novo metastatic was 18.8 to 20%. That means these patients never received any radiation before. 18 to 27% patients were having pure adenocarcinoma. And 11% of patients had less than PD-L1, less than 1%, that is PD-L1 negative. Next slide, please. Tarini writes that 50 mg of cisplatin is standard. Tarini, well taken, comment. Patients, again here, the previous treatment, as we have seen, the none is 18 to 20%. These are the patients who have de novo metastatic disease. 63% of patients received bevacizumab. which is quite high based on the Indian current practice, and Dr. Jaya would tell us about that. Next slide, please. Okay, so this is the PFS curve, and as you can see, the blue line is separating from the red line throughout. Forest plot chart is very, very famous amongst all of us, and we love to discuss. So in the forest plot chart, if we start from the bottom, metastatic disease at diagnosis, de novo metastatic disease, somehow surprisingly hazard ratio was 0.92. Similar was the case when the PD-L1 was negative, and the prior bevacizumab or the concomitant bevacizumab, as you see, when it was not used versus it was used. I'm just throwing determinants, that's all. Next slide, please. Next chart is overall survival data, and this is very interesting. If you see my top left-hand side, PD-L1 CPS score more than or equal to 1, and the bottom CPS score more than or equal to 10, the median overall survival at the median follow-up of 22 months, that is here it's 24 months, has not reached. That means these patients, at least the median survival has not reached even at the end of 2 years. And the forest plot chart again, shows the similar trend as it was showing in PFS, and we will discuss that in detail. Next slide. In terms of the side effect profile, there was not much of a difference between the two. There were 4 deaths in each of the group. Next slide, please. So there was no safety concern that was new, which was thrown in this trial. And FDA approval in the first line is yes. With that, I invite here with our interviewee for today. Can we stop the screen share, please? Yeah, we can switch off. So today's interview is none other than Dr. Jaya Ghosh. Dr. Jaya Ghosh has passed out her DM from All India Institute of Medical Science, as many of us are. We are lucky to passing out from AIMS. She passed out in 2008, and since 2009, she's a professor in medical oncology at ECTREC Tata Memorial Hospital. Dr. Jaya forced me not to talk about her number of publications, so I'll honor her. Though she has 5 publications where she's a first author, and she has 58 plus publications where she's a co-author. Tata Hospital website has one very interesting graph where co-author network, Dr. Jaya Ghosh's co-author network is 456. That means she has worked with so many team members of hers from the various fields. Her main publication target is from the developing world, and their issues in terms of oncology. With that, we invite you, Dr. Jaya Ghosh, and request you to switch on your video, please.
Yeah, sure. Thank you. Thank you,
Okay.
Dr. Amish,
Thank you for being here,
for inviting me to this. Yeah, thank you. It's an honor to be in this. Yeah.
Not at all. So, Dr. Jaya, whether it is an honor, मेरे पे कितना गुस्सा होते हो at the end of interview पता चलेगा.
It's like I'm facing a viva all over again. You said I passed out in 2009, so it's like giving an exam all over again. So I think. Yeah,
no, you remember, you know more than all of us. You have to remember that. So, Dr. Jaya, as we say that the first thing is rapid fire questions, where we request you to answer in short. And after that, we will go on to the main paper discussion. So my first rapid fire question is that out of 100 patients of CA cervix, what you see, how many are de novo metastasis and how many develop metastasis post localized treatment?
Yeah, so after, like most of our patients of CA cervix are advanced CA cervix, and we know that after combined chemoradiation for advanced CA cervix, about 40 to 50% of these patients would eventually, because their 5-year DFS is close to 50%, so about half of these patients would recur, and de novo metastatic would be another, say, around 15% or so of these patients would be de novo metastatic.
So we are looking at 65% of patients who will be eligible for treatment for metastatic disease. disease, fair enough. Do you practice oligomet disease in CA cervix? The concept is very good in many other illnesses, but in CA cervix, are you able to practice oligomet disease with a curative intent treatment, Dr. Jaya?
So oligometastatic disease concept in CA cervix is more of an exception than the rule. And of course, as I was discussing that, sometimes we do have patients with a single isolated supraclavian node or a single bone met, which is just next to the main cervical mass. So there it is, more commonly than a distant met. It is a local bone met which may be treated with a oligomet, and which is rather more of an extension of the disease per se into the bone. So technically it is metastatic, but then those are the kind of patients where we might consider. But as I said, that it's more of a exception that it is
more of an exception. Fair enough. I completely agree with you. What is your first line treatment option in metastatic CA cervix, Dr. Jaya?
So we do give them paclitaxel and carboplatin in those patients who have metastatic CA cervix. That would be our first line.
You say carboplatin and you don't utter cisplatin. I'm surprised, Dr. Jaya. So I would like to know why carboplatin and why didn't you utter carbo/cisplatin?
So yes, we can use cisplatin also, but the reason for preferring to use carboplatin is its better safety and toxicity profile. And with cisplatin, the concerns are patients who've had hydronephrosis and have low GFR. So then administrating is a problem. And whereas with carboplatin, the renal safety profile is better. And also because of overlapping toxicities of neuropathy of both cisplatin and paclitaxel.
Okay, because I'm little surprised. GOG 169, 179, 204 all use cisplatin, and while JCOG 0505 was the only one which said paclicarbo is same as paclicis, and even in that trial, in a de novo patient, they found cisplatin had a very high superior survival. In fact, 23 months versus 13 months when compared with cisplatin and paclicarbo. So I wanted to ask you, Dr. Jaya, again, if there is no contraindication of cisplatin, would you still use carboplatin? Because this is very important for all of us.
If there is no contraindication for cisplatin, one can use paclitaxel and cisplatin as compared to paclitaxel and carboplatin. But many of these patients, so those perfectly cisplatin eligible, no neuropathy. So all of these things also is something that we need to see. But yes, absolutely, paclitaxel and cisplatin is an option.
Is an option. Dr. Jaya, when do you use bevacizumab in these patients? One, and second thing, are you convinced that bevacizumab addition increases survival?
So bevacizumab, we has shown in a randomized trial, it has shown an improvement in survival in patients when added to paclitaxel and carboplatin. But I must say that the challenges that we face with the use of bevacizumab in these patients are that many of these patients have a local recurrence. So if they have, I don't think there is a doubt about the benefit in survival. They have shown an overall survival benefit of almost from 13 to 17, so close to 5 to 6 months benefit in overall survival. But main concerns are about GI fistulas, which in their study was only about 3 to 4%. But it is important then to choose wisely, because if I have a patient who has had previously received concurrent chemoradiation and now has a local recurrence with, rectal involvement or bladder involvement, there, I think fistula will be a major concern. However, in patients with more of distant mets and, less of bowel involvement, if and no other comorbidities, one could definitely use bevacizumab. But, remembering also that almost a fourth of these patients have developed thromboembolism and all these concerns. But yes, it has shown an improvement in overall survival. So in a carefully selected patient, that could be considered. And of course, if cost is not an issue.
Cost is not an issue. And this paper had almost 63% patients receiving bevacizumab. That's what I said, something different from Indian paper, this figure. Do you use topotecan, Dr. Jaya, ever?
No, because of hematological toxicity. One can either use single agent, maybe paclitaxel, that is in patients whom we can't give, who suppose recur within a very short time. So there, single agent pacli is another option that we can use. I mean, paclitaxel and gemcitabine, those are options that are there. But topotecan, because of hematological toxicity,
even though it is NCCN category 1, I don't think so many of us are using topotecan line, and I agree with you. What is your median survival? That is a last rapid fire question, Dr. Jaya. What is the median survival of metastatic CA cervix in your practice?
So as I said that, the median survival of a metastatic CA cervix, if you have to take all comers into picture, it will be anywhere between, of course, I haven't done an audit of our own data, but, it would be of the thing of anywhere between 8 to 12 months. But it also depends upon what kind and when the metastasis has occurred. We might have a CA cervix patient received concurrent chemoradiation and has relapsed after 5 years with 2 or 3 lung metastasis is very different from, and they will have a response to chemotherapy and have another long disease-free survival. Whereas somebody who's recurred just within 6 months of completing chemoradiation and has an in-field recurrence and an out-of-field recurrence as well, their prognosis is certainly very different. So, time, whether they're de novo metastatic and, time to metastasis from their primary treatment, of course, we don't have such a data for cervical cancer, but if you see other cancers like breast cancers also, the time when they have the metastasis, that plays an important factor in their further prognosis.
Correct. Absolutely. So, Dr. Jaya, please remember these figure of 8 to 12 months, because it is very important when we go forward.
And also, so as I would say that somebody, EPOC performance status will also be very important, because someone who has a very poor PS, their median survival may be almost 3 to 4 months. So it depends upon the context, but since you asked overall, that is what I would say.
I understand. I get it. Let's take it as 1 year as the upper ballpark figure in all the patients put together. Let's move on to the main paper, Dr. Jaya. So Keynote 826, I understand based on what you have just said, that they survive hardly for 1 year or just above 1 year. There was definitely an unmet need to identify the new drugs. Am I right?
Sure. Yes, there definitely is, because very few treatment options for these patients. Yes.
Very few treatment options are these patients. So inclusion criteria. Let's go to the inclusion criteria of this NEJM article. More than 18 years, not amenable to curative surgery, RT, accepted, fresh biopsy, archived, and I have gone through that. Do you think that should they have included or excluded some inclusion or exclusion criteria to make this study more uniform?
So I think, if we had taken only de novo patients or all patients of who've been previously treated with chemoradiation, that would have made a more uniform population. But this is like a more real world population of having all kinds of patients in this subgroup, all metastatic disease. So I think that is something that, and also there is about 63% received bevacizumab, but that is the same in both. So, if I had to have of course that is as per the study design, but if we had to have an arm, one would have had an arm without bevacizumab to see whether, they did better or not, having it stratified as pacli-carbo, pembro, pacli-carbo, bev, and maybe having both together. So that is something that one would have wanted to see.
Yeah, after lung cancer, I think this is the second where we have a combination of IO, BEV, platinum, and taxane. I think, that is what has been studied. I personally think that they should have put in exclusion criteria all the contraindications of bevacizumab or all the indications of bevacizumab. That way it would have been more uniform, because bevacizumab adds on to this thing. And as you rightly said, de novo should have been different. But Dr. Jaya, de novo are so less real world scenario, as you rightly said. Absolutely right. So Dr. Jaya, let's move on to the results. Do you want to say anything about the statistical methods? Because there were 6 stratifications in the paper.
Yes.
We don't understand stats much, but you can throw some light on that.
Yes, so they had 2 co-primary endpoints of both disease-free survival and overall survival. And they had these 6 stratification, and they have used a very complex method to see which of, so that all these stratification factors are kind of met. So of course, even to make things simple, it would have been just simple to have a single primary endpoint of overall survival. But I think they wanted to look at both, so they have taken 2. But yes, just one single straight and simple endpoint of OS would have been helpful.
Helpful. Correct. You are absolutely right. And I so wish, when I talk of statistics, I so wish that if Dr. Sudeep Gupta is there, he always throws more light on these statistics. We will ask him to do it later. Let's move on to results, Dr. Jaya. There were 617 patients. As we all know, bevacizumab was given in 63.6% of patients. PD-L1 was positive in 89% of patients. Are you surprised on that? 89% is as good as, you know, anybody you test and would be PD-L1 positive. No other tumor where I have heard such high PD-L1 positivity.
Yes, so as I said, that of course this is a very high number of PD-L1 positivity, and we do not have our own Indian data to say how many of our patients are PD-L1 positive. And also, I don't have the data to say whether there is a difference in PD-L1 positivity when you do it at baseline versus somebody who has received CTRT and now recurred. You know, whether there is an upregulation of PD-1 in these patients, and in a metastatic patient, that's something that I do not know. So it's something that we need to really see our own patients, and make the profile may be different. Yes.
No, you are right. 63% bevacizumab is completely different than what we practice in India, and PD-L1 89% is something like, you know, I feel it's a very, very big number to have PD-L1 so much positive. And they have used a standard DACO platform, and they have used the standard CPS formula. So there is nothing new which they have used. So if so many PD-L1 positive, that means we are looking at probably majority of them are squamous, and we really don't know how many of adenos would be PD-L1 negative. We really don't know that. So let's come to the PFS, and this is the question which probably is India-centric. PFS, there are 3 groups which they have taken: intention to treat, PD-L1 more than 1, PD-L1 more than 10. Okay, in all 3, the PFS at the end of 22 to 24 months is 10.4 to 10.1 months. And in the control arm, it is 8.1 to 8.2 months. Now, numerical difference of hardly 2 months. I again repeat, the numerical difference of hardly 2 months, but the hazard ratio of 0.62, which is very statistically significant. Dr. Jaya, are you impressed by this PFS advantage?
So, see, I think PFS advantage of 2 months is small, but I think for most immunotherapy, we are looking at overall survival differences. So, from that perspective, maybe if we get a OS benefit, that might help. So, in most of, even if you look at across tumor types, the difference in PFS is not huge, but there is a difference in overall survival. So, I think and also as to how we measure PFS, all those factors do come into play.
No, absolutely right. But if you see the Pembro with chemotherapy, other like Keynote 522 in breast cancer, the PFS was not so narrow between the 2 arms. So I was just wondering whether bevacizumab is adding on to response rate. Although the CR was highly different between the 2, response rate was 15% more with pembrolizumab.
Definitely, that
Let's come
difference
to
of
the
2 months
overall
is
survival,
very
and this
marginal. Sorry. Yeah. No, I said the difference
of 2 months
around...
is very marginal. So from very marginal, So from very marginal, let's go on to the overall survival, Dr. Jaya. Survival hazard ratio is exactly same as that of PFS, that is 0.61 to 0.64. But the intention to treat CPS 1, CPS 10, you see the gap of 10% consistent. That is 53% versus 41%, 54% in the arm. There's a 10% of difference in both the arms. Do you think that this is a game changer result in terms of overall survival, which is supposed to be holy grail for practice changing?
So yes, a difference of 10% and in 50, half of the patients surviving at 2 years is definitely an important step forward. Although in the control arm also, I think we've had around 40% of these patients surviving. So that is there, but definitely a 10% survival benefit is not something that we are usually looking at, and that too in overall survival. So I think that is something that is very important in this.
Dr. Jaya, you mentioned about the control arm and very, very intrigued. People who can't afford pembrolizumab, based on minus audit the data, you assume that approximately 1 year, 2 months is the overall survival in India at your institute, in your practice. Look at the control arm. 40% of patients are alive at 2 years. This is something actually the control arm has outperformed all the other. Bevacizumab meta-analysis showed 16 months was the median survival, overall survival. Here 40% are surviving at 2 years. Do you think that this is something the results have changed, because this is just the control arm which is also doing very well?
So yes, the control, and I think if the control arm is outperforming and still we are seeing a difference, then I think it shows that it is really a difference. Whereas if you have a weak control arm, then we can argue that the intervention is good because it is a weak control arm. So, but here in this case, since we have a control arm which is outperforming, yet pembrolizumab is showing a benefit, I think that would be important.
That would be important. Absolutely. I personally think that when I looked at the control arm, I felt probably the natural history of CA cervix has changed in last 2 to 3 years, and people are living longer and longer. Probably bevacizumab we should consider more and more. I know Tarini is one of the favorite topics is bevacizumab in CA cervix, and he will talk about in panel discussion. So we come to the third last question
about Dr. Sahu has raised a question on use of immune checkpoint inhibitors after that. So I think that is something that I don't think we have the data in the paper as such right now. Yeah.
We don't have the data in the paper as such. They have. This is the first sort of analysis, and I'm sure there'll be second and third like Keynote 048, and I'm sure Dr. Vineet Talwar sir will take that up in the panel discussion. So coming to the third last, but one of the most the controversial topic of reading the forest plot chart, Dr. Jaya, and nobody can expect better reading than people in TMS. In plot chart in this Keynote 628. There are the 3 things which came up. I will not talk about age more than 65, we'll leave that aside. But one, radiotherapy patients did better, or the de novo patient did not do well, and the hazard ratio of 0.92. Bev versus no Bev, not much of a difference, although Bev was slightly marginally better, and PDL1 less than 1%, again, the hazard ratio close to 0.96 means not statistically significant. Is this forest plot chart deciding about our practice where not to give pembrolizumab, or you would not read too much into it?
So I think, that's a kind of general dictum about subgroup analysis in the forest plots is that they are not powered to detect it. However, they're definitely, kind of hypothesis generating, but nevertheless, in this patient, taking on your last point first, for a PDL1 less than 1%. Now, there were hardly 10% or 11% of these patients who had a PDL1 of less than 1%. So for somebody who has a PD-L1 of less than 1%, and my major inclusion criteria, if you look at what is the patient population is PD-L1 positive. So the results of the study and the intention to treat study is driven by the majority of the population. So therefore, taking that and applying it to those who are less than 1%, I don't think would be appropriate, and even the forest plot shows that. So therefore, I think the conclusion here, and even if you look at the paper in one line, they've just mentioned that there was no difference between those who had a PD-L1 of less than 1. So I think I would definitely not use Pembrolizumab in those who have a less than 1% PD-L1. And secondly, with regards to de novo metastatic, now de novo metastatic were almost close to, I think, 30% of these patients who had de novo metastatic disease. Now, what is very intriguing is that patients, so in between, it is just bang in between. If you look at the hazard ratios, they are just staggering unity. So that is something very different. So therefore, it is important to know whether, is there something that our patients who are de novo metastatic, there it may not help, and whether in patients who have relapsed and therefore immunotherapy may help. So we don't know the answer to that, and presently I don't think we are powered to say that we will not use it in de novo metastatic. But I think definitely more work needs to be done in that area, and that is something we should definitely look into that population.
So Dr. Jaya, let me ask you, and please answer in yes or no. De novo metastatic CA cervix with PD-L1 1% positive from 3 different labs, money is not an issue. Would you use Pembrolizumab in this group tomorrow or not?
Yes, of course, not an issue. I would definitely discuss this because it has, shown an overall survival benefit. So yes, we'll discuss that.
So let's see if Dr. Vineet
sir I would want to, really know whether it is helpful in these patients or not. But yes.
Right, absolutely right. We will wait for the real world data also here. I personally think that the previous exposure to radiation increases the IO sensitivity. That is what I think. Toxicity concerns. Did you think that any new toxicity was thrown upon?
No, I think most of these are IO toxicities, and like with hypothyroidism is one of the toxicities that was mentioned. So I think that is there. And one more question, I think, which I last when you mentioned about bevacizumab, then I think the thing is what was intriguing, although I'm hypothesis generating, is that in those who did not receive bevacizumab, the IO hazard ratios crossed unity. So that is something I think is more intriguing. But
it is just touching the unity. Yeah. It is just touching the unity. I personally think that let's not read too much into the forest plot chart, when we, look at the bigger picture. But each, I agree with your point. The last you, Dr. Jaya, and then we go back to Dr. Parikh, sir. Is this paper a practice-changing paper from tomorrow itself?
Yes, it is a practice-changing paper, definitely. For it has shown an improvement in overall survival. And one more point, if you allow me to make, is that of course we don't have the data as to show. But interesting thing, if you see in the protocol, is that they have stopped in patients who have achieved CR. The protocol said that it will stop after 8 cycles. I think that is something which we would really want to look at in the future papers, because if we can stop and still retain the benefit, although the numbers here in patients who had discontinued therapy because they had a CR was only about 1 or 2 of them who had discontinued. But there was a protocol provision for discontinuation after 8 cycles or 2 cycles after they've achieved the CR, and minimum of 6. So that I think is very, very important from a perspective of, if I can achieve the same kind of benefit for giving it 8 cycles and then stopping, that is something I think I would want to look at those results in the final paper.
Yeah, you are absolutely right. So according to Dr. Jaya, this is a practice-changing paper. She will not use in PD-L1 negative, and she will wait for some more data for de novo metastatic Till that time, other patients she will offer if the patient can afford. Thank you so much, Dr. Jaya. And please stay tuned because you are one of the panelists also. Over to Parikh, sir. Thank you so much.
Thank you.
Thank you very much, Dr. Amish. Thank you very much, Dr. Jaya.
Thank you, sir.
Before we move on to the panel, it is my pleasure to introduce Dr. Vineet Talwar. Of course, as usual, I can say that he does not need any introduction. But instead of focusing on his academic achievements and why he is such a well-respected KOL, I must appreciate the Indian flag in his background, which is actually a photograph taken by him in the real world when he was going for a morning walk. And the other thing that I came to know is that Vineet and Rajiv Gandhi Cancer Institute are doing the conference in the subsequent months, which will be an in-person conference. And that will be a great opportunity to meet everybody. So Vineet, thank you very much for that. With that unusual introduction, I hand it over to you. You will now follow up on what Jaya has discussed, and with your panelists, see what is the applicability and what is the real world practice in India as far as metastatic, recurrent, and persistent cervical cancer is concerned. Over to you, Vineet.
Thank you very much, sir, for the kind words. And I thank Dr. Amish also for giving me this opportunity to delve on an issue which is really a burning topic nowadays. And of course, rightly, as he said, it is an unmet need at this point of time. So I think I'll just share my slides. And I would like to invite my esteemed panelists, Dr. Jaya, she's already there, Dr. Sahu, Dr. Kripa Shankar, Dr. Nikhil, Dr. Akhil, Dr. Srinath, and one and only one Gane oncologist, Dr. Satinder. So I welcome you all to this panel discussion. And this is just going to be a reiteration of what has been delved upon with Dr. Jaya by Dr. Amish. So according to this trial, initially it was chemotherapy, and now we moved on from chemotherapy to chemotherapy plus Bev, which showed overall survival benefit of about 4 months with a good hazard ratio of 0.77. So at this point of time, I'll ask everybody, I'll start from Dr. Jaya. What is your preferred regimen at present? Dr. Jaya, please.
So for most of our patients, and because, cost is, and the kind of patients who have cervical cancers and cost is a major concern, the most common regimen that I use is paclitaxel and carboplatin. But as I discussed, that could be, that is what I use presently, but yes, sir.
So you don't give Bev in these patients?
So for most of our patients that we see for metastatic cervix, bevacizumab is just out of reach.
Reach. Fine, fair enough, fair enough. So we go to the private circuit, Sahu, and then Kripa. What are your preferred regimens?
Sahu here. So for me, I think I go with Jaya. The most of us use the Pacli and platinum. The platinum would be carboplatin preferred, but yes, cisplatin data looks much stronger. The second thing is that I have used Bev in some of the patients, and I somehow like to use the Moore's criteria. I feel there is a way to use it, and it does make sense that it is only helpful in the mid and the high risk patients. So I do use it, although, and there is a publication to that effect. So I would save money also, and unnecessarily would not use in the low risk. So that has been my practice.
Correct. Kripa, what is your take?
So again, sir, I think like you rightly put it up on the slide, it depends on whether it's de novo metastatic disease, whether the patient has received prior platinum or cisplatin. In somebody who's not received prior cisplatin, definitely I would look at using cisplatin. But if somebody has already had cisplatin in the prior chemoradiation, then I would look at using carboplatin in that patient, Pacli and carbo. And like Dr. Sahu rightly mentioned, I would use the Moore score as well as a way of segregating these patients into intermediate and high risk, and offer bevacizumab to those patients who fall into the intermediate or the high risk. So So that's what I do in practice.
Fair enough. Nikhil, any change, or do you agree with the same?
So Nikhil is not there.
Nikhil is not there.
You can,
Okay,
yeah, you can.
Dr. Akhil and Dr. Srinath, any changes?
Sir, it's somewhat similar only. The only change is that a lot of patients have paclitaxel-induced neuropathy even at 6 months and 8 months, and that is why most of the time we need to use gem carbo in these patients if the patient is fit enough for the same. And also one point which we need to consider is the residual toxicities of the prior treatment. For example, if patient is having VVF, fistulas, we are very thoughtful not to use bevacizumab. That is what we think, and avoid using bevacizumab.
Yeah, I think everybody is skeptical whenever you have any bleeding diathesis or fistulas, then definitely Bev is out. Dr. Srinath, anything else you would like to add?
No, sir, nothing. Absolutely, I agree with all of the above.
Can I make a comment, sir?
Yeah, sure.
I am a gynecologist. I am a surgeon. But we have seen a few patients which are who have been put on bevacizumab by medical oncologists, but there are quite a few. We have seen bowel perforations, much more than what has been reported. Probably most of these patients have received chemoradiation previously, though these perforations usually are not like complete perforation peritonitis, and once the BEV is stopped, they are small perforations, and if BEV is stopped, they usually heal on their own. Patients usually do not require laparotomy, but we have seen quite a few patients having perforations once.
I think we'll come to that. This was just a start to make. So I think we agree, all of us, that paclitaxel plus platinums, whether it is cisplatin or carboplatin, that is the way to go forward. And as Dr. Jaya rightly mentioned, finances plays a major issue. So if finances is not a deal, then you can add bevacizumab. And as Sahu and Kripa had said, that in the high risk group, that is the one which is to be preferred whenever Bev has to be used, barring, of course, as Dr. Satinder said and Dr. Akhil said, that if you have any problems which would be related to Bev, fistulas or all, then of course the bevacizumab is out. So at this point of time in India, the basic combination is a combination of paclitaxel plus carboplatin plus minus Bev, whichever the situation it might be. So with this background, we move to the basic discussion, the Keynote study, in which majority of the patients were squamous, and about 25 to 30% were adenocarcinomas, and the others which were the adenosquamous. So the basic question comes is that if you have a localized relapse, Dr. Satinder, then what do you do? Would you send the patient to us, or would you deal it at your level, or what would you do exactly?
So it depends upon what is the previous treatment of the patient. If patient has undergone only surgery initially, then we send directly for chemoradiation. Even if it is a central recurrence, we usually do not go in for exentration, we send for chemoradiation. But if the patient has received chemoradiation previously, and now depending on what is the site of relapse, if it is a pelvic relapse and it's a central recurrence, we usually plan for exentration. If it has reached up to lateral pelvic wall, or if there are any distant mets, patient is referred for chemotherapy. Right.
So does the histology of a non-squamous matter? It has been discussed. The histology of a non-squamous matter to you in cervical carcinomas?
Sir, I'm not really sure, but if I look at the analog and put the other story of lung cancers, and we have found that squamous cell, they have not done very well actually. The adenos have done better. So I really cannot, I would not tell that would be the major difference, and I would not mainly differentiate, but I'm not sure if there is a difference, because I don't think there's any high quality data to speak about that in cervical cancer.
Kripa, what is your take on this?
So I think, so if you look at even the trials inclusion criteria, so like rightly said, around 76% had adeno, another 18 to 19% had adeno, and another only 5% had adenosquamous histology as well. So I think the magnitude of benefit was definitely much lesser in that cohort, but albeit the numbers weren't too high. It was only around 18 to 19% had adenocarcinoma. And that sort of mirrors what we see in practice as well. So we really have to wait for data on a larger scale to actually say whether it's going to be beneficial in that subset. But as of right now, probably I would stick to using it only in squamous cell carcinomas.
So definitely you would prefer squamous cell carcinoma, which I think I also agree with you. So histology is one aspect. The next aspect are the biomarkers.
So are we proposing, sir, that in a
we'll come to that, so don't worry. We'll come to that. We'll summarize. We switch over to the other aspect, which is the biomarkers, which is the key point in the Keynote study. So you have 89% patients which have been included as PD-L1 positive, and you just have 11% which are PD-L1 negative. And if you just chew around with the statistics, you find that about the groups, that is which is PD-L1, PD-L1 greater than 10, and the intention to treat, there is a tight grouping of the hazard ratios. So with this, I think, Srinath, do we need better biomarkers, or are you happy with this marker for this study?
I'm happy with the marker, sir, but I need more data about how much positivity rate is there in Indian patients. And most of the platforms used here are SP263, if I'm not wrong. 22C3 came in very late, actually. So still, according to the blueprint,
This we use the 22C3.
Yes, sir. Yes, sir. So I'm happy with the marker, sir, but I need more data regarding Indian patients, sir.
So what I meant to say was the interpretation of the data when you have just 11% negative cohort with a 90% positive cohort. Do you think it is slightly skewed?
It is definitely skewed, sir. Definitely, we need more data regarding the negative. I mean, impact of pembrolizumab in negative patients.
Okay, fine. Akhil, you have anything to add?
Completely agree with these comments, sir. Definitely in PD-L1 negative, I don't think that this study merits utilization of a costly drug which has a doubtful benefit in PD-L1 negative. And also the biomarker, PD-L1 is an imperfect biomarker. We are all aware of that, and we need better markers, but the search continues.
So when we have an imperfect biomarker, what do? We rely on the VEGF data. So you have 2/3 of the patients who have taken. Yeah, Amish. Yeah.
Sir, on what basis are we saying on this study, where is the data written that we need a better biomarker? Of course, PD-L1 negative, I take the point of everybody, but PD-L1 positive 89% also I take well. But where is it saying that this is a bad biomarker?
No, I never said this is a bad biomarker. I just said that in this study, when we have just 11% which are negative, can we take out distinct conclusions as to which one is better and which one is not, or there is a need for something else? Only that was the assumption, nothing else. So we go to the other one, the other big boy which was there in the trial, that is the VEGF, which was given in about 60%, that is 2/3 of the patients. And here again, if you again go deep into the data, the OS and the PFS increased marginally in the BRAVE group with the hazard ratios, that is 50 versus 48% versus 66% in these cases. And it was rightly mentioned by Dr. Jaya that when you had only the CT and the PEM arm, the confidence intervals crossed 1 when you saw the forest plot. So let me ask Kripa straight, the addition of BEV vis-a-vis the side effects, do you think it has made a large difference when we give it as doublets vis-a-vis when we give it as triplets with the immuno-oncology combination?
So I think, like you rightly shown there as well, sir, the response rates were definitely higher with bevacizumab, number one. But a word of caution is patients who have had prior chemoradiation. And even if you look at the GOG 240 study as well, all the patients who had a fistula or perforation were patients who had received prior chemoradiation. So in somebody who has not had prior chemoradiation, the rate of fistula formation is much lesser than, or even the perforation rates are much lesser than that. Number one, as far as the adverse effects are concerned. And as far as the addition of bevacizumab, even though we always talk about not paying much of attention to the forest plots, if you look at the forest plot as well, I think what we saw from the interview as well, the patients who had bevacizumab, the magnitude of benefit was slightly better. And let's remember that about 60% in both the arms had received bevacizumab as well.
Correct.
So I think, yeah, it does matter, sir. Yes.
Right. And talking of the real-time scenario, Dr. Satinder, you were mentioning about the incidences of perforation and side effects in patients whom you had operated. Did you chance upon patients who were operated post-BEV and who had perforations? How good or how bad was it to do the surgery, and how many you could salvage? Just an offhand thought. I wouldn't ask you for the exact numbers. Was it an easy situation, or was it a tough situation? Can we get out of it easily?
So not for cervix, but for ovarian, yes, we have operated patients post bevacizumab, but usually we keep a gap of 6 weeks. So we have not had any perforations as of now with bev for ovarian cancer patients. But we have seen this CS cervix who are on palliative chemotherapy with bev. Those patients, quite a few, we have seen perforations, but they were, yes, after none of them required laparotomy actually. Once we stopped the bev, they were conservatively managed and they were taken care of. So not very bad.
So that is the real-time inputs which we have when we compare it to the side effects in the trial which are there. So chemo plus pembrolizumab only, the utility, because that was again reaching unity. So what are your thoughts about that?
So before that, I have a little slightly different take on the BEV issue, sir. What I take on the issue is that when you're adding the immune checkpoint, BEV really does not add anything else. So that's how I would take it, that curve little right, little left. Statistically, if I look at it, the way I look at it, that if you are trying to add a PEM to the chemotherapy arm, probably BEV is not adding much to that. So that's my first take on how I read the forest plot. And coming out to the chemotherapy and the pembrolizumab on the metastatic de novo, I think that's what you asked, Talwar.
Yeah.
So this is one consistent finding, which is there are 3 consistent findings which I'm looking through. If I look at the PFS and the OS in the forest plots, first thing is that in the metastatic de novo, the addition of immune checkpoint is not beneficial. The second point that comes out is the less than 1%, the 10% of the PDL1 who was less than CPS negative, they do not work. That's number 2. Number 3, the BEV addition really does not make a difference if you're adding pembrolizumab. This is the 3 takeaways for me.
So I think which we are trying to sift through the data, and we find that BEV would be a red herring. Yeah, Amish, you'd like to add something?
Yes, sir. This is not a debate going on, but whatever Tarini said, so let's not forget that in Keynote 826, the control arm has done far superior to any other publication done so far in the overall survival of CS cervix. In de novo patients, sir, we really don't know. We are comparing with post irradiation. So rather than saying that IO is not adding much in de novo, we can also say that the post-RT, the IO addition has made a difference, and IO addition in de novo probably has increased the overall survival, but not statistically significant compared to the other arm. I think that is how I would look at it, sir, and would not disregard IO in that de novo group also.
Just a small.
So let's have a rebuttal from Sau. Yes, Sau.
Yeah. No, it's not rebuttal. The two things that I want to know is the post-treatment. Because we all know that pembrolizumab was approved for post-progression in the patients who are PDL positive. So these patients, very likely when the data comes out, you will see majority of them would have received immune checkpoint in second line. That's point number 1. That would have also made a difference in the higher overall survival in the control arm. That's around 17. And mind you, sir, look at the GOG 240. You are having an OS of 17 months in the BEV arm. And the hazards, if you look at it, was 0.67. What hazard you showed actually was the combination of topotecan and Pacli arm both. But if you look at the Pacli cisplatin in the BEV 240 arm, it was exactly 0.67 hazards for the OS survival. Point number two, what Dr. Amish is making, it has shown in many different trials, the PD-L1 higher group normally respond also do prognostically better in terms of survival. And this group of patients had 90% PD-L1 positive. So is that also making a difference in pushing the curve of the control arm of 16 to 17 months, which has never been ever seen in chemotherapy combination alone?
Exactly. That is what at the inception I asked, that comparing 89 versus 11%, is it fair to come out with a reasonable conclusion? So that, of course, see, that is the trial's folly. You cannot change that now. So Kripa, you being the third umpire, so what you have heard from Amish and Sahu, what would you take out as a summary out of this? Where does Bev stand in the whole of the picture? Can you check out Bev, or should you keep Bev inside?
I would definitely looking at keeping Bev inside, sir, because even in the control arm, like I said, around 60% had received bevacizumab. But if you look at the final OS update as well as of what we have at 2 years, it is 24 versus 16 months, which is almost, even the control arm is doing as good as what we have seen with the GOG 240 data as well. So I would definitely look at keeping bevacizumab in there. Agree with your point, sir, that the magnitude of benefit is primarily driven by patients who are PD-L1 positive. And that's the point that I was trying to make for the squamous histology as well. Because majority of patients were of the squamous histology as well. Because the primary benefit is probably driven by that subgroup who are PD-L1 positive and who are squamous histology as well. So I think I would definitely look at adding bevacizumab, especially if they fall into the intermediate or high risk as per the most criteria.
So I'll put the spanner in the works. None of you guys mentioned that this is the physician's discretion to use bevacizumab. Now, nobody gave the inclusion criteria of what physician's discretion was and what it was not. So, Sahu, what do you have to say for the physician's discretion or indiscretion?
See, sir, this only reflects the practice which they are following in the West. The countries which allowed it, they have BEV which is approved already as per the 240 GOG. But what I really wanted to make, and this argument can go on, we can move on beyond this and probably look at others. But I feel always the forest plot is telling us one story which we don't want to see. And like the curves are, the plot is on the same side, is 30%, 35% is not a small number in a 650 trial. And if that whole number game is showing that the addition of BEV is not making any much difference, I would read into this that
you still don't agree with that.
Yes, sir, I totally
fair enough.
I would just want Dr. Jaya here. Can I say one?
Yeah, please, Dr. Jaya.
Yeah, so I just wanted, completely agree with Dr. Sahu in that sense that, if I had to use pembrolizumab, then rather than use Pacli, Carbo, Bev and Pembro in a PD-L1 positive patient, then I would just use Pacli, Carbo and pembrolizumab, although that thing does touch unity, rather than have all four. So because we don't know when we are using Pembro, what is the additional benefit of adding on bevacizumab?
Right, you have a fair point. So I think we have discussed metastatic disease at presentation. Srinath, what about patients who have had prior chemoradiotherapy? According to the trial, they benefited. So what would be the explanation for that?
Sir, there are two, as Dr. Amish sir rightly pointed out. One is whether the radiotherapy is adding, generating neoantigens and adding to the immuno-oncology effect. The other way of looking at it is a de novo metastatic disease in cervix, which is a locally advanced disease. Is it a bad biology and it's not responding to the agents? So that is one way I would like to look at it. I don't know which one is right between both. It can be both too.
Right. I think that is the most plausible explanation which can be there, the sensitization to the immuno-oncology drugs. So, Akhil, what about the sites of recurrence? If you have recurrence, say I have a patient who has a recurrence in the abdomen, say in the para-aortic lymph nodes, or I have a patient who has a recurrence in the supraclav lymph nodes along with that, or we have something in the pelvis. Do you think the sites of recurrence also make a difference when it comes to the overall outcome? Dr. Akhil? Is Dr. Akhil there? So I think anyone, Sao, you can take this.
So for me, the site of recurrence in my practice, what I've seen is the locally recurrent whenever it comes is a very dirty thing to do. We land up with the maximum problems there, the local infections, the fistula, these all things happen. So that looks to me a difficult disease to look into, but will I change my practice as per that? The only thing I look into is the BEV addition. If it's a prior chemoradiotherapy as discussed with a local, I'll be very, very skeptical of the fistula it develops. Other than that, I do not much differentiate in the way I treat it.
So I think it can be taken in the same.
Yeah, the only thing is I always ask my surgeon if they can do something on a local part. If that is not there, then it potentially becomes an incurable disease for me.
So I just wanted to add, Dr. Talwar, to the fact that if they have a isolated para-aortic nodal recurrence, then in that scenario, we would just use radiation to an isolated, I mean, if it's a small para-aortic nodal recurrence, then just radiation alone might also suffice in these patients, and whether to take them as
you're absolutely right, because see, even that and these sites, suppose you have a recurrence at the para-aortic lymph node level, and if you have another one at the supraclav, the outcome radically changes when you compare, with supraclav being worse. So that makes again we talked a lot about the adverse events in the discussion, and that is a very, very important part, where you are using a VEGF, you're using chemotherapy, you're using the immuno-oncology drugs. So Dr. Jaya, IO versus control arm, what are your thoughts? Are these side effects justified in the trial arm, or do you think you would have had some other thoughts?
So I think as compared to IO side effects, they are similar, and as we would expect in other IO arms. But I think a lot of these side effects are also because we have now 4 agents: Pacli, Carbo, Bev, and immunotherapy. So we do not know how one would fare over the other. But yes, if you look at if there is an OS benefit, probably managing with these side effects for at least the 6 months, because we must remember that after 6 months, the chemotherapy, 6 cycles, the chemotherapy has stopped, and then we've continued with Bev and immuno.
Yes,
so we do not know whether most of these side effects are during that time, and once they cross that, what is the side effect profile and whether that is well tolerated. So that is something that we need to look at.
Yeah, this is always there. We keep on talking about the confidence intervals, the forest plot, and we also talk about the curves which are splaying apart. So, Kripa, key evaluation features for assessing the clinical value of therapies. So this is in context to this study, where you had some patients who had CR, and then you had most of the patients who had response rates. So this question is always discussed in most of the panel discussions whenever we have the immuno-oncology drugs. So out of these 4, which one do you think would be the most valuable when you talk of this trial? Could it be the duration or the durability of the response, or the overall survival, or CRPR? I think you can answer it after that, Sahu, and then Dr. Jaya.
So I'd probably definitely look at overall survival here. And probably one thing that I would like to add here is also the quality of life, because I would probably be interested in knowing about that as well. So overall survival with the quality of life, I think those would be my 2 important parameters.
Right. Quality of life, is now a benchmark whenever you do the studies nowadays, because that adds to the power. Definitely that should be included, because the QOL indices in this study were almost at par with the control arm. So any thoughts?
Yeah, so first thing
duration?
For me, it's 4, which is leading to the second. The duration of response that happens, IO is sustained, and that's leading to the benefit what we're seeing in the survival also.
So excellent. We have a dichotomy here. Dr. Jaya, What?
It's not a dichotomy. It's the extension of what he's saying, sir. You are creating a debate-like scenario, sir.
No, I'm just trying to chew, like, you know, the
And about the quality of life, sir, a small rejoinder. This trial did have this data. And one more thing, that is data that is being there but not very highlighted, is the because of the duration of response that happened, the quality of life deterioration was much lesser in the immune checkpoint arm. That's the only point.
Yes, yes, that's right. That's right. Yes, Dr. Jaya, you're the third umpire here. So you have overall survival, and you have the duration of response and the durability, which we put more stress when we give the IO drugs. Which one would you choose?
So if I have to choose one, it is overall survival, definitely.
Yeah, you had mentioned it in the interview. Yes, fine. Why not the duration of response? Don't you think in IO setting, the duration of response has more weightage as compared to the OS, more so when you have a OS at 24 months only? Don't you think a longer OS would have sufficed, and you put more stress on the duration of response when you are assessing at 2 years?
So yes, so definitely, because in these patients, the durability of response is important. But I mean, if I have to choose between overall survival and durability of response, I would choose overall survival. But the durability of response is an important factor in these patients, because, as was also mentioned earlier, that it also improves the quality of life, because if they have a durable response, I think that is something which is important, and that would also be an important factor for considering that. Yeah.
Right.
The second point is, sir, I've always felt that's why the PFS is not that great in immune checkpoint, because the durability of response they do have. That's why the OS benefit is there. And that's why I meant that ultimately it's OS, but because OS is beneficial because of the factor 4. That's what I meant.
Yeah, see, both of them are reciprocal, but both are dependent on each other. But definitely, once you have the duration and durability, that definitely translates logically into the overall survival. So these were the graphs which Dr. Amish had shown. So now the India-centric analysis, we'll have pot shots. Kripa, biomarker negative patients, PDL1 more than 1 or PDL1 more than 10. Which one would be most preferable to you?
So I think for me, if the PDL1 is negative, I wouldn't want to offer them, an immune checkpoint inhibitor, simply for the simple reason being that the amount of money that is being sent does not qualify for the magnitude of benefit that they actually derive out of it.
So I'm asking you the India-centric view.
Exactly,
more the better, or would you give it at PDL1 also?
More than 1%, I'd be happy at offering it, even in patients who have a PDL1 of more than 1. Less than 1, I wouldn't want to offer it, especially in a low middle income country like India, sir.
Right. Dr. Srinath, as per the data which we saw in primary metastatic disease, it is quite a fluid situation as far as this trial is concerned. Would you like to give in this situation?
Yes, definitely, sir. There is still a proven overall survival benefit in the ITT. So definitely explain the data and definitely push for it if the PDL1 is more than 1%.
Dr. Akhil, what is your take about the adenocarcinomas in cervix? Dr. Akhil or Sahu, you can...
Sir, I still believe I will offer it, sir. I strongly still believe I'll offer it. And
you will strongly believe you'll offer it, or you'll just...
Yeah, I will if the PDL1 is more than 1. So that's the point. And for the primary metastatic, I just wanted from anyone who's there, even Dr. Amish, was there a test of heterogeneity which is there in this paper anywhere which was significant for anything in the subgroup?
Amish.
I'm not aware, Tarini. I'm not aware.
Yeah, I think if that is not, although we know that
checked up, it was not mentioned.
Yeah, if that is not, then even in primary metastatic, all of us will offer it. If that was significant, then we might not have. That's what I meant.
So, Dr. Jaya, addition of BEV, what would be your final verdict as far as the India-centric analysis is there?
So I think if I have to use IO so if a patient has PDL1 positive, I would use Pacli-Carbo IO. And if it is PDL1 negative, then probably one would use Pacli-Carbo BEV. That is how I would kind of... think
I
of
think
strategy.
that's a fair solution to
And
be
of
proud
course, and also no contraindications for BEV, of course, that means.
Fair enough. Fair enough. That is there. That is there. And Dr. Satinder, since you are a ringside an analyst, I'll put it, with the medical oncologist in the ring. Finances, how do you view it from outside? Keeping the finances into the picture now, since till now it was only a purely academic discussion. How would you see this 35 cycles, and the costing would be anywhere about 3/4 of a crore? What is your opinion? Do you add it or not?
So we all know CA cervix is a disease of low socioeconomic status people.
Exactly.
Majority of the patients are low socioeconomic status. So I think affording Paclitaxel also becomes very difficult for few patients. So then adding BEV, so it will be very limited number of patients who can actually afford this thing. So definitely,
I think we agree, all of us. Any other differences in opinion? So finances is one of the biggest prognostic factors when it comes to any treatment as far as India is concerned. But barring that, all of us agree that if PDL1 is more than one, if the patient does not have any problems which are related to BEV, then probably this quadrate can be given. So, Dr. Yeah.
Can you just
Dr.
add, that, it also depends, the cost benefit ratio reverses when the cost of the drug comes down. So the same thing, which is not, something trastuzumab 10 years back versus now, there's a huge difference.
Same is for BEV. Same is for BEV,
BEV, yes.
We have the generics now, so we can have the luxury for giving these drugs.
So one more thing which I would put for a financial point is the CR rates. And Dr. Jaya also mentioned that in the interview that if there's a patient has CR, you just give 2 more cycles and stop it. And the CR rate is a very astonishing 22% to 25%. And that really gives me a thought that if the patient has even a moderate and more than moderate finances, and the CR you are going to achieve 1 in 4, you might stop after 6 to 8 cycles or maybe 10 cycles of Pembrolizumab. That also could be a silver lining in the whole data. That's how I feel.
Yeah, so but for that you should have a aggressive patient with an aggressive protocol. Both should match.
And Vineet sir, if I can just quickly add,
Kripa, please,
those CR rates are with the combination of Pembro plus bevacizumab as well. So they're not only for IO as well. So we'll have to take that into account. And since Dr. Sahu said he's not a huge fan of bevacizumab,
probably he might change his mind.
No.
He will not change his mind.
Okay. Just the last line. I don't think there's any data in this trial of a CR which is differential as per the BEV. I'm sorry. If there's something, then I would like to know on the WhatsApp.
I don't think that was mentioned in the paper. You are right.
But there was a difference in the CR arm between the control arm and the addition of pembrolizumab. And the addition of pembrolizumab happened in patients who had already had bevacizumab as well. So I think we don't have the data as of now to just add only pembro to the chemotherapy. I think this trial looked at addition of pembro to bevacizumab and chemo as well. So I think that's...
But 40% of these patients did not receive bevacizumab. No? So it's not like it's a 10%. So I think
it's in both the arms.
Correct.
Balanced for both the arms.
Correct. It was balanced in both arms, and the 1/3 of patients who did not receive bevacizumab, the magnitude of benefit was slightly lesser, albeit based only on an exploratory subgroup analysis.
In both the arms,
I think plot.
One arm it was 60%, the other arm it was 61%. So they were very well balanced that way. Right. So I don't think I have much time. Dr. Jaya, you can see the post-IO dilemma. We talk of giving all of the things, at one go, lock, stock, and barrel, and more the merrier. So giving PEM, is it once only therapy? Point number one. Can we reuse it later, or can we use it in second line instead of giving it now, giving everything at one go? What is your take on this?
So I think I would use it only once rather than, re-challenging again with pembrolizumab. I don't think we have the data in cervical cancer. The other thing is that for someone, like we know that 40% do well with even paclitaxel and carboplatin. And we have the option of using second line single agent pembrolizumab. So for a patient who has a de novo metastatic disease, that is also an option to give chemotherapy and then, or chemotherapy plus Bev and then re-challenge with Pembrolizumab in the second line.
So any
So
data
that is something.
where you can re-challenge IO after an IO as far as cervix is concerned?
I just have a slightly different take on that, sir. I think,
Yeah, Kripa will come to you. If she can answer this question, then you can take over.
Sorry.
Any data of IO post-IO treatment or post-IO?
No, I'm not aware of that.
Yeah,
I think.
actually, I am also not aware. Sahu, anything you have on that?
No, sir, I don't think so. I only have two things to say. In once only therapy, no, if a patient has achieved a CR and I have stopped it, and if let's say the relapse after let's say 1 year, I would be very tempted to restart. That's point number one. There is data from the lung scenario when we have done that and seen that they respond. Do we use it in second line, reserve it, or we do it in first line? I strongly believe, I don't know, I may be wrong, sir, but when this data comes out for the post-treatment, this longer control of 16 to 17 months is the first time we have seen in cervical cancer. This could be because this has been pushed by a second-line IO. That was my thought. So this does give me a data. If that data comes out, that if you can have the money to afford IO, it should be first line rather than second line. That's how I look at this.
The first chance in this case is the best chance, especially since Dr. Jaya told that we are
because you have an 8 months difference. That's also something we have never seen.
And again, as I said, the durability of response, which you have only with IO, that probably if the curves parallel out, say after 4 or 5 years, then definitely this would have a very strong benefit as compared to what it is now. And Kripa, you were planning to say something?
Yes, sir. So, I mean, if you look at the second line approval for Pembrolizumab, it was based on a phase 2 data. We're looking at only response rates. And the response rates in that study, the Keynote 158 study, was only 12%. And that's how the FDA actually ended up approving it. So, if I were to use it, I would probably end up using it upfront rather than using it in the second or reserving it.
I think upfront makes sense. Dr. Srinath, any difference?
I absolutely agree with that, sir.
So I think we are all in the same line, and I bring back the same question again, so we can have a quick, opinion. Dr. Jaya, now this is present after this discussion of this trial.
And, so and finances are there, sir. That's important.
Finances are there, so finances are there. Don't worry.
So yes, Paclitaxel and IO in a PD-L1 positive patient. Yes.
So you are still skeptical about them.
Yes.
Let's see, Sahu.
It's the same, sir. I started the debate.
So 2 people for no BEV. Kripa, what do you want?
I would definitely use the quadruplet.
So I mean, you go for the quadruplet. Srinath?
So I'm for the quadruplet, sir.
Quadruplet. So Dr. Satinder, from the ring side analysis.
So again, with everything, if finances is not a concern at all, then all the 4. If there is some concern, then Paclitaxel with IO.
Satinder, you should tell no, babe, because you have to operate after we do a good response.
I don't know.
So I think the consensus is that the first chance is the best chance, and with the data which we have here, even though it is at 2 years, it is very promising. And once it becomes more robust, then probably this is the regimen which we take to go forward. And the last words by Dr. Amish, and then I hand it over to the organizers. Amish?
I think, sir, you have summed up well. I don't think that we will ever reach. You never asked me, but I would agree that if finance is not an issue, no contraindication, I would go for quadruplet in the first this thing. That is what we don't have any data of anything else but looking at this paper. But otherwise, you have summed up very well. And with Tarini around as the panelist, you always have good debates going on. Thank you for that. Over to Parikh, sir.
Thank you very much, Dr. Vineet, Talwar, and the panelists for making this so much interactive and of value to the audience. Thank you, Amish, for the comments as well. Now it is my honor and duty to introduce our expert who will give the concluding remarks. That is Dr. Kalaichelvi. She has experience both from the government setup as well as in the corporate world. He was earlier professor and head of medical oncology at Madras Medical College. And now, of course, she is in the most successful corporate chain of hospitals in Chennai. So looking at it from both perspectives, she will really be able to tell us what is the value of this so-called practice-changing paper in the real world as far as India is concerned. Over to you, Dr. Kalaichelvi.
Thank you, sir, for your introduction and for inviting me for this session, which was very nice. Actually, I did not participate in your previous sessions of this OBTO, but I think in future I should participate to know better about other aspects of your sessions. And now coming on to the real world scenario, where we have advanced CA cervix is around 75% in our setup in government hospital. And private hospital, you hardly see any CA cervix. In a corporate setup, we never see a CA cervix. Very rarely we come across a CA cervix with metastasis. If you see a CA cervix, it is either a very early stage or it is the pap smear showing abnormality. So in that scenario, we are very successful in treating the CA cervix. But the advanced stage or the metastatic disease, the survival is only 17 months in literature, and in real world it is around 12 months. As Dr. Jaya pointed out, it is around 8 to 12 months generally because they live longer. The locally advanced disease people live longer with the disease. The CA cervix is the advantage in these people is they don't die quickly. And when you have a metastatic disease, it usually they start with lung metastasis or the supraclavicular nodes, where you give salvage chemotherapy in real setup. Now that you have pointed out about this paper, where I'm yet to try pembrolizumab in CA cervix, it is metastatic or it is recurrent disease. And there was a question about persistent CA cervix, which is actually if you don't achieve a complete response after the standard chemo radiation, then it becomes persistent disease. And later it progresses. So it is either persistent disease after standard treatment or recurrent or metastatic disease. In these patients, usually after the standard chemo radiation, we usually come across, the treatment of Parikh. There were times when we used only cisplatin as single agent, and then paclitaxel came used as single agent, and then bevacizumab. This was the natural history of evolution in the treatment of cancer cervix. And we have had good responses in people who had only lung metastasis after 2 or 3 years of standard chemo radiation. And now this paper where they've used pembrolizumab along with bevacizumab and Pacli carbo or cisplatin, where they have found or they have succeeded in showing a PFS benefit and overall survival benefit, and which actually it is better to see this much of response, like 50% of your patients are living for 24 months, and that is really good enough. And if you look at the negative side of it, it is the only financial problem. Second is the side effects, the immunotherapy side effects, as well as the bevacizumab side effects. I wouldn't use bevacizumab in my practice along with the immunotherapy for for the sake of cost, as well as for managing the side effects of bevacizumab. Not every patient is suitable for bevacizumab. The panel discussion has shown very well. And people who have limited disease to lungs or supraclavicular nodes or retroperitoneal nodes plus local disease, maybe we can use them with Pacli, cisplatin or carboplatin with pembrolizumab, which may give us some benefit, or complete responses also in some cases, where we have achieved complete response with only Pacli and bevacizumab in many patients with lung metastasis in my practice. And this paper actually, apart from all this PFS and OS benefit, and you have the duration of response, which is quite good in people who had pembrolizumab, and also the complete response was 22%, which was very good in this setup. And also the people who had the quality of life, which was better, and the compliance was better in the pembrolizumab group than in the placebo group. And also the maintenance, the quality of life in these patients during the trial was much better in the pembrolizumab group. So if you look at the paper practically or literally like that with their perception, it looks very good for use in practice. But in real life, I think it will be very difficult for us to use this drug. For each single dose, it might cost you around 4 to 5 lakhs, and which is not possible even in a corporate setup. And I have used pembrolizumab in other setups of ovarian cancer, lung cancer and renal cell cancers, where I think people were supported by insurance and corporate and other central government schemes. And it's much easier to use there. And I don't know whether I'll be able to do this in the setup where these are in the socioeconomically poor background. And in a study from MSKCC, where they have mentioned that apart from PD-L1, the clinical features like presentation with only lung or lymph node metastasis, or squamous cell carcinoma, or tumor burden which is higher than 10, may be a predictive marker for using pembrolizumab. I think that I would take it. And in that study, retrospective analysis, they've mentioned that adenocarcinoma has not shown any benefit with pembrolizumab. So I think I will be cautious in using pembrolizumab in patients who have adenocarcinoma, or because adenocarcinoma patients do respond very well to paclitaxel and bevacizumab. I don't know whether I should really use pembrolizumab in these patients. And I think this study, they have mentioned in the inclusion criteria, irrespective of the PD-L1 status, they have been included. Later, they have been done with PD-L1 testing, where they have found, used that IHC CC23 PharmDX method for identifying PD-L1 status, and they categorize the patients. So some of the comments that irrespective of the PD-L1 markers, sometimes pembrolizumab does help patients with CA cervix. But apart from that, I would be very cautious. I will use only when the PD-L1 marker is more than 1 or more than 10. And then when they have limited disease and the favorable sites of metastasis like lung or lymph node or supraclavicular node. And when you have an extensive local disease, or when there is an involvement of the bladder or rectum, I would be very careful not to use bevacizumab along with this regimen. Using 3 drugs itself is very difficult, and using 4 drugs is going to be practically difficult. And if you start using, you will know how much problems you face in practice. And if a patient develops problem in a corporate setup, you'll be thrown into pieces, and they will ask you 101 questions, and you have to manage the patients round the clock, and it's quite difficult. I would be careful in selecting the regimen. But of course, this paper is convincing, depending on, looking at the overall survival and, the compliance status and the duration of response. Everything seems to be good in favor of pembrolizumab. So people, when they can afford, and we have to explain, and the patient should understand the implications, then we can use this in real, in practice. I think that will be my comment. Sir, would you expect anything more?
Thank you very much. No, this is perfect, Dr. Kalaichelvi. The way that you compared what happens in the corporate world as opposed to what happens in the government setup, that is exactly what we hope that you would have brought out. And I thank you very much for this. Amish, for your comments, and then I will share the details for the next meeting.
Sir, I think it all went very well. Just one small comment, which was a request to everyone. Absence of evidence does not mean there is an evidence of absence. We have talked a lot about adeno-CA and immune checkpoint inhibitor. I think we'll have to wait for some time before we can say that in cervix, the IO does not work well. There are a lot of case reports where there is a complete response to pembro in CA cervix is there, but we never talk about case reports as an evidence, sir. So I would just say that let's wait for some more evidence before we discard that group. That was my last comment, sir. Over to you for the next thing, sir.
Thank you very much, Amish. I would now like to remind our audience that our next OBTO is on 5th April from 7 p.m. to 8:30 p.m. The publication that has been selected is adjuvant osimertinib in lung cancer ADAURA trial. And again, we have a galaxy of experts there. The interview is Dr. Kumar Pravash from Tata Hospital. The moderator for the discussion is Dr. Ullas Patra. And the expert comments will be given by Venkatraman Radhakrishnan from Adyar. So again, a feast awaits you. And please join us again on 5th April at 7 p.m. sharp. With that, I thank everyone once more for the expert comments, for the discussions, and for patient hearing. And I now request Kavina Creations to close the meeting. Thank you very much.
Thank you.
Thank you, sir.
So much.
Thank you. Thank you.
Thank you, sir. Thank you.